With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi, everyone, and welcome to the October 2019 edition of PRS Journal Club podcast. I'm Kyle Sanniec, PRS Resident Ambassador from UT Southwestern, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Raj Parikh from Washington University in St. Louis. Today, we have the honor of being joined by Dr. Adeyiza Momoh. Dr. Momoh is an associate professor of surgery and is the Integrated Plastic Surgery Residency Program Director in the section of plastic surgery at the University of Michigan. Thank you so much for joining us, Dr. Momoh.
Thanks for having me.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing is Intraoperative Surgical Navigation Reduces Surgical Time Required to Treat Acute Major Facial Fractures by Dr. Bergeron out of Quebec, Canada. The purpose of this study was to see if the use of intraoperative navigation is allowed to reduce surgical time in these acute complex major facial fractures. So the authors designed the study in a retrospective quasi-experimental way where 50 patients ultimately met the inclusion criteria. They looked at major facial fractures and they assigned them to a group either with or without navigation. They ensured and excluded cases that were only isolated fractures or multiple fractures with comminution. They wanted to better control for the complexity as each craniofacial fracture can be different, so they devised a facial fracture severity score to control for bias and to better determine the complexity of each case. In total, 22 patients were treated without navigation and 28 patients were treated with navigation. When accounting for severity, the surgical time was reduced by more than 2 hours, or 36.1%, in the surgery group that was treated with navigation. The authors concluded that the study shows there is a significant decrease in the length of craniofacial procedures when using navigation, and argue that the use of intraoperative navigation will benefit patients in the acute fracture setting. I think it's a very intriguing study. More advanced imaging and navigation has been reported in oncological reconstruction literature and complex delayed trauma reconstruction, but hasn't really been discussed in the acute setting. I think the study does shed some light on the benefit of using navigation from some of the more complicated fracture patterns. The other thing I think is nice is this FAST score that, while not the main indication of the study, I think it allows readers to conceptualize facial trauma patterns in a very nice way. And at least for me, when I listen to those, it gives me a good idea of how difficult a stabilization will be by just kind of conceptualizing the different severity indexes they talk about. As I read this study more, though, I do wonder if this is applicable to all centers. There's several kind of questions that come up. First of all, intraoperative navigation. Most settings are quite expensive and it may be cost prohibitive. And using this over intraoperative CT, which more and more centers have, makes me wonder if they would be willing to spend the extra money for the navigation systems. Additionally, I'm not sure how they calculated time spent setting up the machine, if that also added to the total OR time, or if they didn't start the OR time until the case physically started and they put a knife to skin. I'm also not entirely sure if most hospital settings can have the infrastructure to set up these intraop navigation systems that are often not set up for acute craniofacial trauma settings. With that being said, I think this is a very interesting article, and if it in fact does decrease these really complicated operations by 2 hours, I think that's better for everyone involved, both the surgeon, the patient, and the healthcare system as a whole. So with that, I'd like to ask Dr. Momoh, what do you think about this article in general?
I read this article with a lot of interest, trying to get a sense of what exactly it was they did with the navigation tool and how that actually decreased the amount of time spent operating for some of these complex craniofacial trauma cases. And I thought it was very interesting, and I do like their findings. There are a number of things that stood out to me. Usually when I read these articles, I'm looking at the study design to see if a lot of the things that were done to set up the study made sense. And if they do make sense and if the design is appropriate, then you can at least trust the outcomes. And you can say that, okay, what they found is valid. So in reading this article, these are some of the things I looked at. One of the key things that kind of jumped out at me was the randomization based on the equipment availability. So essentially, based on equipment availability, patients either had the navigation tool utilized during their operation versus not. And because the availability of the equipment was somewhat random, the authors felt that the patient groups were randomized appropriately. I kind of question that a little bit because one of the questions that does come up is, do surgeons have some latitude in deciding on when to schedule cases? And is it possible that some cases were not scheduled on days when the equipment would not be available? So that's the question about randomization kind of came up when I was reading this. Going beyond that, the timeline for the study, I don't know if I fully understood this, was set up so that they captured patients who they treated about 2 years before and 2 years after the introduction of the navigation system. And if the idea was to capture patients that were operated on within the same time period, just based on randomization with availability of equipment, why look at patients who were operated on before the introduction of the navigation equipment? And many times when retrospective studies are done and patients are not treated around the same time, as in some patients were treated for about 2 years before another group of patients were treated, you always wonder about a change in the operative experience of the surgeon. Now, with an experienced surgeon, the assumption is they are really experienced, and so there's no big change occurring over a period of a few years. But I think for all of us that operate on a regular basis, I think we continue to grow. I think our operative experience continues to improve, and so the changes in time that we see, especially knowing that a good number of patients had operations performed prior to the navigation tool being available, you wonder if some of the time difference we see is related to surgeon experience. So that's a second point. A third point that came up in reviewing this had to do with a critical aspect of this study, which is facial fracture severity score. I don't think the authors had much of a choice but to try to categorize or classify the fracture patterns to determine which ones were severe versus which ones weren't, and then ultimately select the study cohort. But in doing this, I think what they depended on was the senior author's experience and one person's experience in determining or at least defining the categories. In reading this, I came away feeling that the facial fracture severity score were essentially like counts. Essentially, for a certain fracture pattern, a score of 1 was given, and then for another fracture pattern, a similar score of 1 was given, and it was all that way. Nothing was necessarily weighted. And so, essentially, with combinations of fractures, what you had were counts that were additive. So with that, I question whether or not the severity score is valid. And would it have been possible, would it have been better to have multiple experts look at fracture patterns and then, as a group, come up with a consensus of what makes sense? Would it have been better to weight certain fracture patterns and certain combinations of fractures as opposed to assigning equal values to each of these fracture patterns? But the problem I see is if you do not agree with the fracture severity score, then it kind of affects the results that they found. So those were some of the issues I felt were prominent and things to consider when reading this article and interpreting the results. Ultimately, they're finding that they had equal distribution of the severity scores between the groups, I think was reassuring, and they did work hard to try to control for the severity scores in looking at their ultimate outcomes. But I would have also liked to see maybe a distribution of severity scores between the two study groups, not just a mean or standard deviations, but actual distributions of fracture severities for the two groups to see maybe in a tabular form so I can see for myself what kinds of patients were being treated in each of the study arms and determine if their findings were agreeable or at least were supported.
I think those are all great points you bring up. As I was looking at the article with a lot of these, I wonder if this study is applicable kind of to the general plastic surgery community or the community plastic surgeon or even the academic center plastic surgeon who's taking facial trauma call. I mean, how many fractures do they need to see to make this cost effective? What are your thoughts on at least the clinical applicability of using intraoperative navigation for treatment of these complicated facial fractures?
I really like the study because it appeals to an aspect of plastic surgery that is vital to our future. We continually look for ways to innovate. We continually look for ways to do things better. And this, to me, is one area where the authors are applying a technology that exists in other fields to something that is relevant to us in plastic surgery. So I definitely applaud them for this, and we have to continue thinking this way if we're going to come up with new ways to do things and better ways to do things. So from that standpoint, absolutely important. From the practical standpoint as to whether or not this can be used for other areas of plastic surgery or in general just for facial trauma, I don't think we're there yet. I think this is probably an early step to assess the feasibility of applying or employing this technology. Like you have mentioned, it probably is very expensive. The authors do admit to spending a lot of time to set this up with engineering staff, probably from the hospital, helping to put things together. And that is not accounted for in the amount of time it takes to do the operations, essentially the groundwork and the setup time to get all of this up and going. But the reality is, if, as with most things, if there is an application for this in plastic surgery, if there is enough volume, the companies that make the technology will probably put in the efforts to make it more user-friendly and probably eliminate some of the hurdles that are necessary for setup, or at least that these authors had to go through to get the technology set up for themselves at their institution. So too early to say whether or not this would apply at other centers, but probably worth taking a closer look at to see costs, the time necessary to set things up, and actually figure out what patients would this be worthwhile using this technology in, because this was obviously not assessed in patients who have simple fractures, but in patients with complex fractures. So the question is, would this even be valuable in patients with simple fractures, or do our traditional techniques, are they good enough? My thought is our traditional techniques, open techniques, are probably good enough without the navigation equipment, but things like this probably have come into play or might have a role in more complicated fractures where getting a better sense of how the different bones come together in a three-dimensional view would be worthwhile and time-saving.
I think those are great points. I also like the point you bring up, which I think is maybe a way to kind of bridge the cost-effectiveness gap, is a lot of centers already have these navigation systems set up for oncologic head and neck reconstructions or for some of these more acute delayed trauma presentations. And if the plastic surgeon, it's just sitting there not being used, it's a great way to be able to utilize stuff that's already there at the center that they can just try to transition more for acute facial fractures. Raj, I wanted to see what you thought. What are you guys doing at WashU? Are you using any kind of imaging on these really complicated fractures intra-op, or just more of the standard clinical operative techniques?
We used pretty much the standard traditional techniques. We haven't used intraoperative navigation with any regularity. I think initially when it came out several years ago, we trialed it, and I think there were some difficulties just getting the scans with the CT technology and getting the navigation set to where you had a consistent read, basically, for symmetry. So we've occasionally used like the O-arm, the intraoperative CT for orbits and things like that, which is not live navigation, obviously, just to check the position of the implant. But other than that, no, we pretty much do a traditional approach. I think the point that Dr. Momoh made and you made, Kyle, is that's very important, is how much time on the regular bread and butter fractures is this going to save you compared to what the cost is, and then just the cost up front of learning how to use the technology. And I would say that, for a lot of what we do, in my opinion, it's not going to make a significant difference, a clinically significant difference as far as the time it would cut off for things like mandibles, straightforward mid-face fractures, ZMCs. I think maybe in the cases that it would help would be, these pan-facial fractures. But even then, depending on what exposure you have, if you're doing a coronal, your exposure is pretty good for the reduction. So it's hard to say exactly where this would be beneficial. I do think that the more experience you have with it, obviously, the more efficient you're going to become. But I would say that I don't have a whole lot of experience with it, and I feel pretty comfortable with the traditional approaches. So it would have to be something where I'd have to look at the cost if I were to implement it in practice going forward.
That's a great point, Raj. And I also wonder, the surgeons that are doing this, by the time you start getting enough reps that you're doing the navigation, they get so used to the fracture patterns themselves, they almost self-select because they're just doing more and more craniofacial trauma cases that, maybe by the time you're at that point that the navigation becomes easy. Is it because the navigation itself or just because you have so much more experience doing these complex fractures? Lily, what do you think of the article?
We do a lot of facial trauma here at Duke. We have a pretty high volume for that, and we do a couple different things for navigation in the OR. We have the CT operative rooms that we use for certain cases, and I think you guys have mentioned an orbital floor. That can be a great case to get an intraoperative CT because it would save you a potential return to the OR. And then we also have the brain lab technology. And so we don't use this necessarily for all of our fractures by any means, but this is what we're using frequently for the really complex panfacial trauma and for patients who've had virtual surgical planning, sometimes with custom implants for the midface or for the orbit, and for that we find it useful. I also had that same question that was brought up earlier about the time to set this up. For us, I feel like most of the time it's smooth and it doesn't take that much extra time, maybe 1 or 2 minutes. But their devices, they're actually securing and screwing into the skull, it sounded like. So I would presume that would just be part of their overall operative time as opposed to, some type of pre-incision anesthesia time. But that definitely has morbidity associated with it, which I don't think they really expanded upon that much. I think something that, for the next group that's going to look at this and maybe a little bit more of a rigorously designed study that has more of either, a randomized trial or a little bit of a better control of some of the potential biases that were existing here would also be to look at reoperation rates, because I think that's where sometimes intraoperative imaging can really help you. You may get fooled that things look okay to you from the perspective that you're able to appreciate in the OR, either from whichever incision you're making, but the intraoperative imaging is what may help prevent you having to come back to the OR after, traditionally you may have gotten postoperative PanRx or postoperative scan on these patients. So I think that would be something to include. And then, 36% just really stands out to me as a huge reduction in time. And I don't know if this seems reasonable to people who have more experience going with both intraoperative navigation and not intraoperative navigation, but it just makes me feel like maybe there's something else that they're capturing, and maybe this is the residents at their institution all of a sudden after they had the intraoperative navigation really struggle without it, or something else that otherwise the study is not capturing. It just sounded like a really impressive reduction in the time of their surgeries.
Yeah, Lily, you bring up a good point, and it's one I was thinking about as I was reading it. I wonder if some of the surgeons become very dependent on the live navigation to the point that maybe they aren't as facile with just standard techniques, operative techniques, if they start relying so much on that navigation system. But I agree, 120 plus minutes of saved surgical time, if that's accurate, it's pretty remarkable. In terms of cost savings, most hospital systems, operative time is per minute is the most expensive thing in the hospital budget. Dr. Momoh, I think what kind of lasting parting words would you want to give the listeners of the podcast about this article?
I think it's a good article looking at potential change or potential paradigm shift in the way complex facial trauma is managed operatively. It's a first step. However, I would think this technology needs to be looked at a little closer. I think a study design that addresses a lot of the weaknesses that are present in the current article would be necessary. But I would be neutral. I wouldn't dismiss the technology, and I wouldn't adopt it right away without additional information to see how it would pan out from the standpoint of time, cost, and the differences that exist between what is used traditionally in expert hands versus with this introduced as well.
Great points. And with any article that we bring up, it's always good when you can get more and more questions about the article to really kind of hone this. And hopefully this article will bring that out, and there will be more studies from larger centers or multi-institutions that come out to try to prove or disprove this. I think the patients will do better, and the healthcare system as a whole will do better if it is proven on a larger scale that this is getting that kind of surgical savings. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune in to the other 2 articles that we'll be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Momoh, for joining us.
Thank you very much.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.